If you're ready to unlock more better days, to take control of your health, to push past your limits and unleash your full potential, then you're in the right place. I'm your host, Dr. Jeremy Bettle. For over 2 decades, I've worked with elite athletes and high performers, helping them optimize their bodies, strengthen their minds, and recover from setbacks. Now I'm bringing that expertise to you through the Vitality Collective podcast. In each episode, we'll dive deep into the science, strategies, and real-world solutions you can apply right away. Whether it's enhancing your physical performance, avoiding or recovering from injury, sharpening your mental edge, or simply feeling your best every single day. With insights from top experts and thought leaders, this podcast is designed to help you take action, feel better, and live the life that you deserve. Welcome to the Vitality Collective podcast, where every day is vital. Today I'm joined by Dr. Tom Walters, a leading expert in pain science and physical therapy. With over 17 years of experience as a practitioner, Dr. Walters has helped thousands of people understand their pain and take control of their recovery through his platform, Rehab Science. In this episode, we explore the fascinating world of pain science, discussing why pain doesn't always mean damage, how stress and sleep impact pain perception, and why movement is one of the most effective ways to manage persistent pain. If you've ever felt stuck in the cycle of persistent pain, this conversation is for you. Let's dive in. Okay, welcome back everybody to this episode. I'm really excited to have my great friend, Dr. Tom Walters, with us today. We're going to talk about pain science. And we were just talking before we hit record here. One of the reasons I reached out to Tom to do this episode, the people who have come to us who are in pain, they've been rejected out of the healthcare system. They've tried so many different options and all they want is some relief. And this is just this unrelenting presence in their life. And when they finally find someone to potentially help them, it's just like, please help me. And so I'd love to dig into that with you, Tom, and understand a bit more about what's going on for these people.
Yeah, man. Well, thanks for having me on. First of all, this is like we were talking about beforehand, most of us are going to be affected by pain at some point, and most of us will have those acute or subacute pains from an injury or you tweak something. But 1 in 5 people now, it's said in the statistics, have persistent or what we used to call chronic pain. And I just think there's so much that unfortunately most healthcare providers are not educated well in pain education, pain science, and physicians get very little of this in their training. Physios like myself, physical therapists, have more around pain, but a lot of the schooling is still kind of outdated models, what these kind of postural, structural, biomechanical, very mechanical models of pain. And that is getting better over time as we appreciate more and more of how the nervous system and the immune system, how these different systems are involved. But I think so many times people go into practitioners and the practitioner either just isn't trained in kind of the intricacies of pain, or it's a lot of times I think is just the way the way healthcare is set up right now with reimbursement, insurance, and providers just don't have a lot of time with people. So, and usually the thing that gets chopped is some of the talking element. And that's so important when it comes to pain because you really need to understand it. There's a big educational component and a lot of coaching that goes into it. You kind of have to understand pain, and you have to work together with someone almost like a psychologist in a way or a counselor. You know, I think I was telling you the other day, a lot of what I do now is really almost more pain coaching. And a lot of that is talking with people and coming up with a plan. And it's less of what I would have done in my early days as a physio. I've been a physio for 17 years now. In the early days, I would have just had them get on the table. I would have started working on them, giving them a few exercises. There was always the beginning of kind of checking in and see how they were doing. But I think I realize more and more how important it is to spend time chatting with people and listening to them and really kind of discovering what unique elements go into their situation that's driving their pain, because you really have to try and peel back the layers and get to the bottom of that to start making changes for people.
Yeah. Well, I tell you what, let's dig into understanding what we're talking about a little bit here. I'd love it if we could set a baseline of some definitions. So you've talked about acute and subacute pain. We've talked about persistent, and we used to call that chronic pain. Can you delineate some of those for us and what we're going through, the physiology at a high level, and just so we can really understand what we're talking about?
Yeah, for sure. I think it is helpful to understand those things because there are kind of characteristic symptoms and time frames that go along with those, and that kind of can help you figure out what type of pain you have, and then that
Mhm.
helps start you on the pathway to, well, what should I work on in terms of interventions to get rid of this? And so you can think about it from a time standpoint. So acute pain is something that's just happened, right? It's
Mhm.
really recent. It's in just the last few days. And most people, that will occur when they've actually had an injury or tweaked something. They, were deadlifting at the gym and their
Mhm.
back instantly started hurting, or they sprained their ankle, or they dislocated their shoulder. Like these very obvious kind of tissue insults. You could also just have something that's not where you can't really identify an injury, but you just kind of tweaked. You were doing a workout
Yeah.
and all of a sudden your back's hurting, and maybe you've got more of just a pain that who knows if there's actually an injury. And that's something we often try to help people understand, is that injury and pain can occur together, but they're different things.
Mhm.
So you can have pain without an injury. You can have an injury without pain. So helping people kind of put those together. So you've got that acute, really fresh type of pain. Subacute is usually out to a month is what you'll see in the research. So
Yeah.
maybe you had knee surgery or something, and you did have some kind of injury, and that pain that's kind of out to a month, maybe out
Mhm.
to like 2 months. A lot of tissues in the body, the time frame for different tissues to heal
Yeah.
varies, and a lot of that's based on the blood supply to the tissue. So
And can I just pause you for a second, Tom?
yeah.
And I want you've said something that's really important a second
Mm,
ago there, that injury and pain can come together, but they're not the same thing.
mm-hmm.
Help the listeners understand the separation between tissue injury and pain.
Yeah, they're really important to separate because most people think that pain means damage in their
Hmm.
body. And that can happen, but you would usually be able to recall pretty easily something traumatic, high force that happened to your body, like you were running and twisted something, or you were something really heavy, an external load was placed on your system, and
Hmm.
or you felt a joint dislocate or something
Hmm.
pop, and you heard a
Hmm.
sound like so. Tissue insults like that are associated with pain. Usually, it's pretty easy to recall something traumatic, high magnitude that happened to your
Yeah.
system. A lot of the pain conditions in the people I see nowadays, there is nothing like that. Or maybe there was years ago, but they
Hmm.
still have pain. And so in a lot of those cases, there's not actually there's no damage to their tissue, but there's an activation of their
Yeah.
pain system, or maybe you could think of it as like a flare up of their pain system if it's something they've had in the past. So
Hmm.
it's really important for people at a base level to learn that pain and injury are different
Yeah.
phenomena, and that pain doesn't always mean tissue damage. We have
Yeah.
lots of research showing now that you can have pain when you don't have tissue damage. You can
Hmm.
actually, there's actually research where researchers will make people believe they're going to have tissue damage, and they will experience pain even though it's all just you're faking them out, like through
Right.
virtual reality, different
Hmm.
things like that.
Hmm.
So it's really just if you look at the International Association for the Study of Pain, they'll say that pain is a sensory and emotional experience
Hmm.
associated with actual or potential tissue damage. So you have to think, if your brain thinks there's the potential for damage, it can create pain.
Yeah.
So actual and potential tissue damage. So of course you have actual tissue damage. Sometimes that will create pain. Sometimes it doesn't.
Yeah.
I'm sure all of us can recall situations where you just see you have a bruise and you have no idea when that
Hmm.
happened. You never had pain. Like that's a bruise is an indication of tissue damage. So you see this in sports, in military situations. There's lots of things where people have much more severe injuries, but they don't report pain at the time
Yeah.
because it wasn't important for them. It could have been detrimental to them to experience pain at that moment.
Sure.
So it is really important to separate those two. So I'm glad you brought that up. You really have to go into thinking about pain as it doesn't necessarily mean there's tissue damage, because when people do think that, there's, as you can imagine, there's a good amount of kind of fear and anxiety
Yeah.
that come along with it, and that often is a huge part of the pain experience. And actually, there's research showing that when you're more anxious and more fearful, it can actually sensitize your nervous system and increase your feeling of pain.
Yeah, and I think that's something we'll put a pin in and just
Yep.
let's remember that going forward for the listeners, because when we start talking about movement and exercise coming out of this, I want to really keep that distinction. So
Yep.
before I interrupted you, you left off. We just got through subacute pain, so we're in that tissue healing phase that might be a month, it might be 2 months, depending on the blood flow to the tissue type.
Yep.
And what sort of comes after that subacute phase?
Yeah, so it does get a little tricky. If you look at the research, after 3 months, pain that persists past 3 months, that's one of the kind of one of the qualifiers for listing it as persistent or chronic pain. You have to be careful with that though, because you and I both know there are lots of tissue injuries that take a year to heal. Like if you tear your Achilles tendon, it's going on for a long time.
Yeah.
Certain things like labral tears in the shoulder, the hip, cartilaginous structures, the meniscus, things like that, they don't heal quickly. So there's a lot of people who have these very tissue driven, what we would call nociceptive pains. That means that they're pains that are coming from the activation of nociceptors, which are danger receptors all throughout your body. So you have them in your meniscus, you have them in your skin, you have them in the labrum of your shoulder, you have them in tendons. And the nociceptive pain, the activation of those danger receptors, is the more mechanical pain. It's what most people will think about, like, oh, if I, twisted my ankle and now I turn my ankle in, it causes pain again because I'm putting mechanical stress on that injured tissue.
Right.
So a lot of mechanical pains, just because of how long some of these tissues take to heal, people can have pain way past 3 months. And so you have to look at everything all together. Just because you have pain past 3 months, you don't want to just think, oh, I have chronic pain and I'm doomed.
Yeah, and I guess the quality of the rehab of the tissue and how well it heals and all these other factors can feed into whether there is still sort of mechanical pain still present.
For sure. Yeah. Yeah, for sure. I couldn't agree more. I mean, the work that you do, you can imagine an injured tissue that it may just heal as you're just sitting there and doing nothing and being sedentary. But as soon as you get involved in something in life that maybe stresses, if you haven't done the necessary mobility and strength work, the neuromuscular motor control work around that, you may put excessive stress on that healing tissue. And now it's hurting again because the muscles and tendons that were supposed to help protect it haven't been trained. And so, yeah, I think, another way you can think about this, so that's kind of the time frame. You can think about kind of acute, subacute, and then getting out into persistent or chronic pain. And those are the three major categories you'll see from a time standpoint. So, but you really have to then look at other characteristics, because time alone won't help you really determine, is this more of a normal acute, subacute pain, or is it chronic? It's just one factor. So you've got to look at other symptoms that would, a lot of this when somebody's coming in is I'm sitting and talking with them and asking them about their symptoms, and really myself as the physio trying to go through and figure out where are they at in this from a time standpoint and from a pain kind of time standpoint, and then what type of pain do they have? Does it sound like it's a more mechanical pain, or does it have sort of symptoms that make it sound a little more like it's not matching up well with mechanical kind of tissues in their body, and it sounds a little more like there's something maladaptive or something that's happening in their actual pain system,
And
in their
what
nervous
sensations
system.
might people be feeling with that? Just give us an idea of what they might be going through.
Yeah, usually what happens is the symptoms they experience don't match up with this what's happening to their body. So it could be something as simple as like, oh, they're having pain in in a particular region of their body, even when they're just completely stationary. They're not putting any stress on it. So it's usually some kind of exaggerated, amplified pain symptom that doesn't match up with what they're actually doing with their body. Or, people have probably heard of some more extreme examples, like where, maybe you apply something that's normally not painful to someone. Like really extreme examples are like light touch, like you lightly touch someone's forearm and maybe you rub a feather over it and the person experiences that as excruciating pain. And so that's called allodynia. It's where someone's having pain to a normally non-painful stimulus.
Mm-hmm.
You can have things that are a little less severe than that, where maybe it is a stimulus that could be potentially painful, but the person's response is completely overblown. That's called hyperalgesia. So I think people just have to think about, like the back pain is a lot like this, where someone might say, "Oh, I bent over to pick up my sock and I was laid up for 2 weeks. Like
Mm-hmm.
I just had excruciating back pain for 2 weeks." There's a mismatch there. Like
Right.
you shouldn't have excruciating back pain that causes disability for 2 weeks because you picked up a sock.
Yeah. Yeah.
Something that that sounds less like, oh, you injured a disc in your back or strained a muscle, and more like your pain system is overprotecting you.
Yeah. And so what causes this sensitization?
Yeah, it's really kind of interesting. And this is where a lot of the pain research is at now. And it really varies person to person, but it's this really multidimensional pain is talked about as being a multidimensional experience. So no matter what, when you have pain, it's a complex process. If somebody has a
Mhm.
mechanical pain, like they sprain their ankle, it's a little more simplistic. But when you start getting into pains that have been around a little bit longer, it really is unique to each person. And there's often a number of factors that go into it. So what you'll hear from a lot of people, if they've had persistent pain, that there's usually things, maybe in their history
Mm.
or at the time of the injury, where maybe they had increased stress levels. Maybe they weren't sleep. A lot of times you hear that with like relationships, like a
Mm.
relationship with their partner, or stress at work, something like that, like a really stressful job. It may have been that they sustained, uh, have had traumatic insults in the region in the past, like maybe they've had a car accident,
Mhm.
or things that maybe have created some fear and kind of
Yeah.
worry already, that
Hmm.
things that have shaped their beliefs. We know beliefs are a huge part of this. This is why the education is so important. Your beliefs around pain. I often have patients come in and say, "Oh, my dad had back pain, so I'm just probably going to get back
Yeah.
pain." Right? Like
Yeah.
people have, we all have different beliefs about things, and those shape our experiences in a lot of cases. And there's a lot of research around this with pain. So I'd say things like that, like stress. Maybe they're not sleeping well. It could be how much they move in general. Like maybe
Mhm.
they were quite sedentary at the time, when the pain started. So it's often not just one thing.
Yeah.
It's like, and people don't recognize these things right away. I often am kind of planting seeds, kind of trying to help people understand, like, what are all the factors that could lead to your nervous system being a little more sensitive.
Yeah. I think that's a
And
tightrope there, isn't there? As
mhm,
you're getting people to understand that, because I run into this a lot with people that come in with this persistent pain. That, and I think this is where the present healthcare system starts to run into trouble, is when we get to persistent pain that isn't necessarily associated with a particular trauma. A lot of people have sort of been led to believe it's in their head. So when we say it could be due to psychological stuff, it could be, from an accident in the past, it could be from trauma, it could be from, a lack of sleep, not to mention the physical adaptation of the nervous system to the pain sensation itself. People immediately think you're almost accusing them of making it up.
yeah, it's a really tricky one to walk, especially if you start trying to educate people and tell them that pain comes from their brain. They're like, "Oh, now you're really saying it's in my head,"
So so
So,
yeah.
man, I've had it. I can't tell you how many times I've tried to help someone understand pain, and they did really just hear it as me saying it's in their head. And
Hmm.
so it's tricky, and each person's different. And
Hmm.
I think you really want people to understand that I totally believe you that your pain is
Yes.
real.
Yes.
Physiologically, it's real. Like your pain system is creating pain to try and protect you.
Hmm.
But that doesn't always mean that something is physically wrong with your body, because that's what people want. They want to find the physical cause. Like when they have pain, they want to go have an MRI or an X-ray, or they want you to do some test and say, "Oh yeah, this is it's your L4, L5 disc. That's what's
Right.
causing your pain."
Right.
Right? But so many people we see that have imaging and go through testing and have perfect reports, so,
Right. Or
and that
or
often,
they find
yeah.
something wrong, do a surgery, and it doesn't get rid of the pain.
Yep.
One of my most recent gentlemen who came in was on his fourth or fifth surgery.
Yeah.
Multiple hernias and hip replacement and back surgery and recently epidural, and we're still going down the line of trying to discover what's the thing that's causing this. And
Yeah.
the frustration and the desperation when you think you've found the thing and you've sort of been given the promise of this is the solution. I think that's heartbreaking for people.
Yeah. And that goes back, and maybe that's one of the most helpful things that we kind of just talked a little bit about is kind of looking at your sign and symptoms and looking at where do they line up? So something that's a very mechanical pain that would be something that is more likely to respond to like a surgery.
Mm,
Those are going to be the mechanical kind of injuries and pains, and those typically are pains that are very well localized to one area. They have very obvious on and off positions or activities. They're just very mechanical, like the ankle sprain example. It hurts right there on that spot in my ankle where those
mm,
ligaments are at. When I twist my ankle in this position, it puts stress on those mechanically, and then it reproduces the pain.
mm,
And when I leave that position, it gets better. Maybe it lingers for a second, but it pretty much gets better. Like mechanical pains will be very obvious like that. People aren't as scared of them because they are more predictable.
right.
Chronic pain is more unpredictable. Like it'll just come out of nowhere. You can't always, it doesn't have clear on and off mechanical kind of positions and triggers. And it freaks people out because of that. It might just ramp up, and that really freaks people out because they feel like they have no control over it.
Hmm.
It can spread. It often doesn't have really clear, localized, defined borders. It'll spread. It could spread to the other side of their body, different regions in their body. So if you have any symptoms like that, surgery is definitely not is really most likely the direction you don't want to go, because you could be in a situation like that where you hear all too often where someone has some kind of orthopedic surgery and their pain is still there.
Yeah. Yeah. And I think at the very least, people need to understand that if it is a part of the solution, it's exactly that. It's one small part. Maybe there is some relief that it can give, but only as a part of this bigger system.
Mm-hmm.
That's something to emphasize over and over, and something I want people who are listening to this who are in pain to first of all hear that it's valid. You are not making it up. This is not in your head, but also that it's very complex, and to try and pin all your hopes on one solution can be very, very defeating in the long run. So I think those are really important points to make. And I want to just swing back a little bit to some of the challenges of the present healthcare system in this. People bounce around a lot from the ortho to the pain management clinic to, anywhere they can go. What I've experienced is that, if you've got pain that's persistent in your foot, you go and see a foot doctor, he examines your foot, and there's nothing wrong with your foot. So out the door,
Totally.
right? And
Yeah.
so how do people navigate this system um, in that challenge insurance based type model?
Yeah. Well, I like what you said a second ago about, just kind of thinking about all the factors and trying to get away from the idea that I'm just going to find the one perfect intervention that fixes all this. When you start talking about pain that's been around for a while and maybe looks like it fits more into this persistent or chronic pain state, the best facilities and groups in the world at treating this are multidisciplinary clinics that really take a biopsychosocial model. So you really have to look at not just the foot. Like if you have foot pain, you aren't looking at just your foot. You're looking at your whole system, because the nerves that go to your foot also go up your leg, into your
Mm-hmm.
spinal cord, into your brain. So you have to be thinking about the so that biopsychosocial model. We would talk about the bio part as the biological. It's kind of the physiological part, mostly associated with your tissues. So you're thinking about, okay, well, like I've got chronic foot pain. I've got those nerves and tissues in my foot. Maybe I had a surgery, right? This happens. Some people, they have a surgery and they have chronic post-surgical pain. So it's like I've got those nerves in my foot. Maybe I had surgery in that area. Those nerves travel up my leg into my spinal cord. Like, what can I be doing to try and kind of alter my physiology? Maybe that's things like exercise. Maybe it's ice pack. Maybe it's a vibration. Maybe it's a TENS unit. There's all kinds of things you could potentially be doing to change your pain from a physiological, a biological level. And there's psycho and social. The psycho part, the cognitive element and the emotional element are both huge drivers of pain. So a lot of this for people is trying to slowly shape their beliefs around pain. There's been, like in back pain, for instance, people who are more likely to develop chronic back pain tend to have the belief that their pain won't get better, that they're going to be stuck with it for the long term. That's like a worry for them. And they kind of have this belief that they may just have it forever. And so that those types of mindsets, the mindset before of like pain equals damage, that belief, the genetic kind of family history belief, there's lots of them out there. So your cognitions, your beliefs, the emotional side, like I said before, anxiety, stress, and depression are all highly tied into the development of chronic pain. Depression, for instance, with back pain, is often more strongly associated with the development of chronic low back pain more than any physical factor. Like most people who have back pain are going to think, oh, my hamstrings are tight, my core is weak. They're going to think about all these kind of physical factors.
Yeah.
When really something like depression maybe is where we should start first.
What's a really interesting point about depression as well, especially as it links to pain, is that it cuts you off from your prefrontal cortex, which is your timekeeper. So you don't know there was a time before pain or depression now, and you don't think that there's going to be a time after. So you're almost completely through the depression, you're isolated in that moment. And as far as you're concerned, there doesn't exist a time before or after other than what I'm in experiencing right now. So it could be such a powerful way to address the pain is through the depression.
Yeah, that's so interesting. I hadn't heard that before, but yeah, you're kind of, that's like your whole reality is that pain. And that like I said, if you can't remember before and you can't imagine the future without pain, you're kind of just stuck. Without depression, you're kind of just in that place. And so the psychological pieces are really huge for people, the beliefs around it. And I think this is where the pain education is so powerful. And again, unfortunately, a lot of practitioners either don't have the time or don't know it, so they're not talking about it with people. And then their side is the social side, which kind of was in line with what you were just talking about. People often become more isolated when they have chronic pain. I think it can be tricky, right? Like if you've ever been around someone who's had a chronic problem, it can get a little exhausting to hear them talking about it all the time, right? And so I think if you're a friend to someone like that, you've got to try your best to be positive and reassuring and be a good friend to that person, and maybe not always like trying to figure out how to fix them, but just listen and be empathetic. And it's a reminder for me too. Like I've been in situations with family members where after a while you're just like, I don't want to listen to this anymore. So, people who are in chronic pain, that happens to them. And healthcare providers they feel like they don't believe them. And then their friends and stuff maybe get tired of hearing about it. And so they slowly become more isolated, which can feed into the depression. And so I think that is another big part, is kind of trying to find, and that might be joining groups, like pain groups. Chronic pain groups are really powerful for people, because then you've got people in there, right, who are not going to be fatigued, or kind of run into that compassion fatigue talking about you, because they're dealing with a similar issue and they want to all work together.
Well, then they're going to feel seen and validated with you, and not so alone. I think, we see it with veterans coming back from conflict zones, and first responders, they are much more comfortable in a group of people who have shared that experience with them. It's hard to come back and relate to people who haven't done that. And I think seeking a therapist or seeking a support group, I think it sounds like a really critical part of this overall management.
Yeah, for sure. I think, just like the example you gave there with soldiers and things, you need to have people that kind of understand your situation that you can talk with. And then, if you can find a therapist or a coach. And I think if someone does feel like, someone like me as a physical therapist, I'm not trained in how a psychologist is trained, right? Like they're finding someone like that can help you work through your beliefs and cognitions and emotions, and also understands pain, is so huge for helping you kind of come up with a path forward. I mean, I kind of tell you just a little story. I sometimes think about this because chronic pain, like we have all these kind of circuits in our nervous system, right? Like little pathways and circuits, and you'll often hear that neurons that fire together wire together. And so this is often talked about in the chronic pain kind of area, where you have this pain circuit, and if you fire that pain circuit more and more, it takes a lower level stimulus to fire it again.
Right.
So it just gets easier to fire, right? And that can happen with other kind of chronic or persistent things as well. And I personally ran into this when I was younger. I had really bad social anxiety. And it was interesting that the social anxiety was triggered by one particular experience in life. I was in grad school. I was stressed out. Kirsten and I had just gotten engaged. And I was standing in this close little circle with people. We're all making eye contact. And I was talking about us getting engaged. And I had this first time in my life, a social anxiety attack. And whoa, it scared the crap out of me. I didn't want to have that happen again. And so my natural response was to avoid it. So I avoided those situations, and particularly eye contact was a trigger for me. So if I had to sit still and make eye contact, like board games, sitting around a circle, worst trigger. And so I avoided those situations, and I avoided eye contact by really trying to meet with people outdoors and wear sunglasses. So if I could block my eyes, I wouldn't have as much social anxiety. But of course, that system got more and more sensitive because I wasn't confronting the issue and I was scared of it. And that just gave it more control and kind of power over me. And so the only way I got out of it, now it's probably 95% gone from where it was 5 years ago. And it really came through taking my own advice that I'm telling people with pain, and really, I need to confront this issue, but do it in gradual little steps and work on desensitizing my system. And I think that's the cool thing. Thing that's so cool about our nervous system, our pain system, all of our nervous system, is that we have neuroplasticity. And neuroplasticity can be bad sometimes in the pain system, because the pain system can become really sensitive and create pain when nothing dangerous is happening to you. But on the flip side, you can use neurosensitivity to slowly desensitize your system and get it out of that kind of really ramped up, amplified chronic pain state.
That's a beautiful story to highlight that. And it's really nice to be able to relate it to something that I think we can all relate to. And it's a great segue into the more hopeful side of this message of what can we do about it. And I'd love to talk about the role of movement and more active modalities in addressing this, because we see a lot of times it's passive PT, it's meds, it's surgery, none of which I think are going to really address this issue. One of the issues when we start moving, particularly if you haven't been into training, is you get sore when you start working out muscles. And so we add layers of pain in, but differentiating those different kinds of pain, I think, is really important. Can you speak a little bit to how we make that progress to begin the motion towards confronting this?
Yeah, I love what you said there at the beginning. We will often break interventions down into passive and active interventions, and we know that passive interventions are things that are done to you. So it's like going to see the chiropractor, the physical therapist, and they're popping your back or massaging you or stretching you. And it could be things like other modalities that are used on you, like ice and heat or electrical stimulation. It could be something like a surgery. They're all things, again, that are kind of done to you. And while those can sometimes have their place in the short term, they don't have great long-term evidence for reducing pain. So they can be useful little coping type strategies if you need them here and there, but kind of beyond 6 weeks, they're often don't have a lot of great research past that time period. The things that really have strong longer term evidence are the active interventions, which really for pain mostly revolve around exercise and movement. And part of what makes those so powerful is that it gives the person control. It really boosts their self-efficacy, because at the end of the day, for us in rehab, your goal is to empower the person and teach them how to self-manage. And the active coping strategies are those things. The person they don't have to be dependent on you. The last thing you want is for the person to feel dependent on you to get them out of pain and make them feel better. You want to give them the tools so that they can do it on their own. And it is a tricky thing, right? Like if we know exercise and movement has some of the best evidence, and that can be lots of different exercise and movement. Like I just was looking at a big systematic review for back pain, and all these different exercise movement strategies scored basically the same. We had yoga, Pilates, a stretching program, resistance training, aerobic exercise. All of those helped reduce low back pain. So I think a lot of times for people, it's just finding the thing that you enjoy. Like find a movement, or just walking. Like you can just be walking sometimes, depending on what type of pain it is. But swimming, like just figure out what it is that you enjoy. And part of that is that there's all the physiological stuff of just moving and what that does to your physiology and your pain system. But sometimes too, like distraction is a really big component of not having as much pain. When you're cognitively distracted, you just pay less attention to, you notice your pain less.
Yeah.
So there's a bunch of elements that go into it. And I think the part you mentioned about soreness versus pain, it is often tricky for people, especially if they're kind of newer to exercise, to figure out. You're trying to help them discover, like, okay, is this just the kind of normal soreness that comes along with exercise that happens to everyone, even when they're not having pain? Or is this really reproducing your familiar symptoms that you came here for? So if it is really reproducing the person's familiar symptoms, a big part of this exercise and movement plan is this graded exposure idea, because most people with physical pain, there's usually some kind of physical movement that will more likely to kind of trigger it, right? Like if it's in their physical body, not always, but a lot of times they have something like that. And so you are often developing a plan that exposes their nervous system to that, but in kind of gradual steps. And that's part of the plan of, like, we're going to first do this, put this little bit of stress on your body, and then we're going to increase that stress a little bit slowly over time, and use that as a way to desensitize your nervous system and help to convince it that movement is safe. So, but it's a tricky one. Because people have the natural thing with pain, recovery from pain, is that I always tell people it's never this like linear, just I'm getting better and it's amazing. Like it's natural to have flare-ups and setbacks.
Yeah.
So you want people that you're always checking with them, like, I just want to make sure you have this positive trend over time, but just know there's going to be little setbacks. And that's just natural. Sometimes you overdo it a little bit and you flare your pain system back up. It's okay. Just give it a couple of days to calm down and then get back on the plan and adjust, in the way that you need to. But those active things like exercise and movement, and that might not, and exercise and movement isn't the only one. Things like mindfulness-based stress reduction, like anything you can do to reduce stress, meditation, what else? It's like, I throw all of those, all kind of fit into the active interventions, because you are having to do them. They're somebody's not doing it to you.
Yeah. That's something I say over and over again. It's the work you do, not the work that's done to you, that's going to get you through this. I think one of the other challenges and one of the big drivers of pain is sleep. And pain is such a disruptor of sleep. And the cruel thing is that then sleep is such a driver of pain. So are there things that people can do to help promote, better sleep? Is there anything that you work with people around that?
Yeah. I totally agree with you. There's so much research on this kind of positive feedback loop between pain and sleep. And so, I think some of it is just general sleep hygiene habits that I know you and I have talked about before, of like, you have a consistent bedtime and wake up time. Trying to avoid like things that might stress you out. I know that's a big one for me sometimes, is like, if I'm viewing something on my phone, like, probably don't look at political things before you go to bed. Like, I think try to like, kind of, if you are going to use it, maybe it's something that's kind of self-soothing. Like sometimes for me, like watching a little bit of a comedy special actually like really makes me feel good, and I'll sleep really well, like something positive and kind of happy that makes me laugh. And that actually has a lot of research for people with chronic pain. People in chronic pain tend to laugh less. And so joke books and comedy kind of specials can be pretty helpful. I think there's things from a blood work standpoint, right? Like maybe there are deficiencies there that could interrupt someone's sleep. And I think there's a lot of power in having blood work done and analyzing things. Last time I had mine done, I was a little low, like in my vitamin D and magnesium and some of these things. So maybe there's sleep aids like that out there that can help people. I'm not actually, as a physical therapist, talking about some of those things as much,
Mm-hmm.
just because they can be outside my scope. A lot of it for me is, a lot of it for me is encouraging people to get enough sleep. So
Mm-hmm.
thinking about somewhere in that 7 to 9 hour window, talking to them about how important it is for healing. There's so much that goes on from the musculoskeletal system and the nervous system standpoint from a healing perspective while you're sleeping. And then some of it can be mechanical, where if some people are triggered, they wake up feeling worse, you
Mm-hmm.
know? And I think sleep can be tricky because you're sort of unconscious and you roll and move into different positions, and it can be something that flares people up. And so sometimes for me, it's trying to identify those positions based on where their pain is at, and then maybe trying to help set up their bed in a way that blocks them from moving into those positions.
Yeah.
So, if they know I've got a shoulder pain and when I sleep on that shoulder, it really flares it up, then it might be figuring out, okay, maybe you can get a body pillow and you could block that side so you can't roll over there, or I've got this ankle pain and when I sleep on my back and the sheets push my feet down like this, my feet hurt more. Like trying to
Mm-hmm.
figure out ways to alter their position so that they're not getting into the positions that flare them
Yeah.
up. So,
Yeah, we did a really interesting episode on sleep with Dr. Melissa Lim. And one of the interesting things that she said is that this anxiety-based insomnia can set up with 3 nights of poor sleep, where you actually then start getting stressed about going to bed because you're worried that you're not going to sleep and you'll be in pain. And that cycle continues. So if we loop back to the stress reduction piece, the triggers for stress and anxiety, one of them can be sleep itself.
mm-hmm.
And so what I like to try and do is actually put in a sleep or a bedtime routine that involves meditation. Maybe it's a hot tub or a warm shower. It involves journaling and gratitude and all these sorts of things that bring the parasympathetic nervous system online, so you have that association with going to bed. She also talks about sleep hygiene, as you so rightly said. So much of our sleep is under our control. In we think about our blue light exposure through our devices, and we're in bed with a TV on, and the bed stops being associated with sleep and sleep alone. So I think you're so right, and there's so much we can do. And then as we get better sleep, our whole catecholamine mix the next day, if we're sleep deprived, we're running on adrenaline. And so all of these stress hormones are released into our body just to keep us awake. And we know that's where the role of stress comes in, right? In pain is through all of these different hormonal responses within the body.
Yeah, I love what you said there about, I think so often a lot of people who fall into being maybe a little more prone to chronic or persistent pain, often you will see that they tend to be a little more type A and kind of hypervigilant, a little maybe more anxiety prone, depression prone. And I think it makes a lot of sense. And I've experienced this with different things in my life where something happens a couple of times and then you start the worry about it happening again is almost worse as it happening again. And so,
Mm-hmm.
I've definitely seen this with people over the years where the worry about maybe it's not getting enough sleep, maybe it's about something else in life triggering their pain, the worry about that happening again is almost more detrimental to them,
Yeah.
or at least as detrimental as the thing actually happened. So I think with sleep, I mean, I've almost experienced that to some degree where I've had a couple of bad nights of sleep and then you almost don't sleep well again because you're worried, you're
Yeah.
getting yourself into that kind of sympathetic
Yeah.
state. And I like the ideas you mentioned there of just how can we tap into the parasympathetic nervous system and kind of calm things back down and get out of that kind of worry, fear, fight or flight state.
Yeah. Yeah. So I really like to have people bookend the day with these grounding practices so that we can bring the nervous system to a set level, so that we're not chasing that or running away from the pain from the minute our eyes open. And it just helps with emotional regulation, with bringing that parasympathetic nervous system online, regulating those stress hormones so that we can get a real objective rating of where we're at versus if we're in that hyper stressed state, very unregulated, will always perceive a much higher level of pain.
Hmm. Yeah, I think honestly, as I've been in my field more and more and interacting with people in pain, I think sometimes the number one driver is kind of like what maybe you would think of as sort of like the person's overall psychological kind of stress.
Hmm.
I just think so often I see that with people that whatever's driving it, and right, there could be a lot of factors, like they haven't slept well for a few nights, they've got a bunch of stress going on at work, they might just be stressed about the pain not getting better and nobody has a solution for them. But it's like that kind of boils up, and it just seems like it oftentimes with people when they can't get their nervous system to wind down, there's just sort of an elevated base level of stress that I think ends up being the almost the most helpful thing that I can do for them. And it might be something that doesn't really even look like a direct stress reduction technique. It might literally just be that I get them on the table. And that's maybe where like manual therapy and some of these things can come in. Even though they
Yeah,
might just have the short-term evidence, I think there's something about the person can lay down, I can move them and work on them, and they feel like, oh, this person understands what's going on. They believe my symptoms. They're working on
yeah,
something that reproduces my symptoms, but it feels like it's changing it. And that helps to reduce stress.
yeah. Well,
And so
and
there's all
yeah,
these mechanisms that go into it.
yeah. There's all those sort of mirror neurons as well. With, like the physical touch from another human being and the co-regulation of your two nervous systems. Just them seeing you breathing,
Mhm.
with a nice calm breath. You're not hyper, you're not breath. Them seeing that in you can help through the mirror neurons, just help their whole system relax. So I
Yep.
think that physical touch sometimes, even if you're not actually doing a manual therapy technique,
Hmm.
just almost being rocked, you know, just to help
Totally.
calm. I think
Yep.
that's such a great point.
Yeah. Yeah. Just having somebody kind of hug you and
Yeah.
like a loved one or whatever, like it
Yeah.
can be huge. Just kind of that soothing to kind of calm the nervous system down.
Yeah. And is there, I'm almost hesitant to ask this question. Is there a timeline that people can sort of expect where there's some sort of adaptation to the nervous system, or um, are these things just so individual that we couldn't even really put a timeline on it?
Yeah, that's hard to say. I don't think I could say there's anything in the research where anything's been pointed out that there's kind of this specific timeline that you can expect. And I don't know that I could say that from working with people either. I think it is really individual. I do think maybe there's sometimes a pattern where if the person's had the pain for longer, like say they've had it for 10 years versus a year, that maybe there's a little more time up front expected if you've had the pain for longer. But I don't know that that's always true either. I do think there is a fair bit of patience that just goes into this and helping to encourage the person that this is probably going to take you some time. If you think about the time that it took to kind of make the nervous system more sensitive, it's going to take some time, probably more time than that, to figure out the steps and plan that works best for your individual nervous system and pain experience to kind of help bring it back down and wind it down and desensitize things. But it's a good question. I don't think I've seen anything that sort of lays out almost like a framework for how long these things take. I mean, sometimes you get some crazy things where people who've had pain for a long time respond really quickly, and it was just about finding the thing that spoke to their nervous system. 'Cause you hear this with people. Sometimes people have had pain for a long time, and they just happen to find the one intervention
Hmm.
that who knows for what reason, like it just tapped into their nervous system in the right way. But I would say, that's usually not the case. I think more often what I'm telling people is that if you truly have a chronic pain condition, a persistent pain condition, the reality of it is we need to shift away from thinking about being pain free and just thinking about what can I do to reduce pain. I think that people sometimes have this expectation that I need to find the thing that gives me 100% pain relief. And that often isn't realistic. I think more often we might think about, okay, well, if I've got 9 or 10 out of 10 pain, what's the level that I could get, if I could get down to it, would allow me to live my life and function in the ways that I want to. And maybe that's getting down to a 3 out of 10. Like maybe if I get to a 3 out of 10, like, oh, this is manageable. I don't really think about it. Like
Yeah.
the reality is most of us have little, I have a pain that started years ago in my thoracic spine that it kind of is there a lot of the time, and it ebbs and flows. And I think, but it's at a level that it doesn't affect me. It doesn't cause any disability. And so I think I'm at a point now where, and even the social anxiety thing, it's 95% better. I've sort of come to terms with the fact that it may not 100% go away, and that's okay. And I think if somebody listening to this has chronic pain, I think that's a good thing to keep in mind, that all these interventions and the work you can do can have a significant impact on decreasing your pain, but it might be unrealistic to think it's going to 100% go away.
Yeah, and there's not probably a thing that's going to fix it and then you'll never have to do anything about it again. I think this is an ongoing process that you work on over an extended period of time, and there's probably some things you're going to have to do to manage it for the foreseeable future.
Yep. Yeah. And really probably things that are good for you in general.
Yes.
Right? Like the things that we know that help with pain, stress reduction,
Yeah.
exercise.
Yeah.
Keep doing those
do all of
when
those.
you're just keep that going. Like those are good habits. Like that would be a benefit of having the pain, is that you develop these habits around these healthy behaviors and then you just keep them going. Like good sleep hygiene, like better nutrition. Like those are all things that are going to help your pain system and help your health overall.
Yeah. And I think with that, Tom, we're coming up on the hour here. Can you give us 3 takeaways? What would be your priority system? Because not everyone can come and work with the two of us.
Yeah, I think, I think if you're somebody who's having pain right now, and maybe you're listening to this and you're not sure if you're kind of in that subacute, chronic pain, something still healing, whatever it is, I think maybe some 3 kind of applied takeaways would be, maybe consider finding a practitioner in your area, do a little research and see if you can find someone as a first concept towards treatment, like a rehab, a psychology type practitioner. It could be a fitness practitioner. Like maybe you can find someone who knows a little bit more about pain. And it might take a little research, because this isn't easy to find online all the time, right? Like it might be some word of mouth, like talking to people, maybe getting into some groups like we talked about. Maybe it's an online group, and maybe it's virtual. Like it doesn't have to be in person, right? Like sometimes it's just find like a coach, like find a pain coach. Right. I think that's so helpful as a first step. And especially when you consider how connected we are digitally and virtually these days, you can find people who are out there who are specialists in pain. A lot of times it's physios and psychologists who are studying this. Like find one of those people that can kind of serve as a pain coach to help get you going in the right direction. I think considering something like that is a good first step. I would say, the movement, exercise, kind of active coping we talked about, like that is another huge element. So I think probably the 2 big ones that stand out to me in that are exercise and movement. And so aerobic exercise probably has the strongest evidence for pain. So just getting your blood pumping, kind of getting into like a zone 2 cardio, but you do have to think about not all aerobic exercise is created equal when you have a physical pain. So like if you have a foot and ankle pain, it might not be that walking and running is the best aerobic exercise example for you. Like maybe it's cycling or swimming or something, so just try to find something that maybe you can do for 30 minutes a day that kind of gets your blood pumping. There's so many benefits to the nervous system, immune system, and the pain system with aerobic exercise. And then I would say in that exercise and movement category, another thing to think about is also just focus on something you enjoy. Like sometimes these things feel like homework. So just try to find something you enjoy. Like I was saying earlier, a lot of these different types of exercise, from Pilates to yoga to just a stretching program to lifting weights, a resistance training program, a lot of these have similar evidence in terms of different types of pain. So maybe just there's lots of options. Think about trying some of those different things and Just finding something you enjoy, because if you enjoy it, you're going to be more likely to keep doing it, and that's what's going to really help you recover.
Mm-hmm.
I think the stress meditation, like to me, the meditation and the other one is the mindfulness based stress reduction. These types of techniques to me often go just really naturally hand in hand with the exercise and movement. And so I think as a step 2, just think about some of those that you can kind of easily implement in your life that don't feel like a huge degree of homework.
Mm-hmm.
And then I would say, I think it'd be unfortunate if I didn't encourage people to try and learn more about pain,
Mm-hmm.
because I do think it's such a major part of recovery from pain, because too many people believe that pain is related to something being damaged or really dangerous in their body. And of course, when you have pain, you want to rule out the sinister things. Like that's the first part of medical care, is rule out cancer and rule out things that, because there are sinister diagnoses that can cause chronic, unrelenting pain. So you need to rule those things out. But once you've gotten past that, learning about your pain system and learning about how pain works can give you strategies. It can help you understand it and give you strategies to almost kind of change your self-talk and kind of talk to your brain and say, like, listen, I know you think creating this pain is helping me, but it's not helping me in this situation. And it's not necessary to have this kind of exaggerated pain response. And so, education around pain can kind of give you it can help to shape some of those beliefs, maybe some of those negative beliefs that you're carrying, or maybe some information that's not helpful that you might have even heard from a practitioner who didn't know much about pain, who convinced you that your pain is because of this pelvic obliquity or this leg length discrepancy, and you've got to keep coming back here so I can fix it. And they've made you dependent and shaped you with beliefs that keep you into a pattern that isn't allowing you to heal. And so, there are lots of different books out there on this, but one that's really a neat one that's written by a pain psychologist is just called The Pain Workbook. And it's essentially kind of like a book on reframing pain, and sort of revolves around cognitive behavioral therapy, but it's called The Pain Workbook, and the gal who wrote it is a pain psychologist. So I really think that's so powerful. And anywhere you're at, even if you don't have pain right now, just learning about your pain system and what it's designed for, and really reframing it to, we want to be grateful for the pain system. It helps keep us alive and helps us survive. And so many interventions, especially in the medical world, are about blocking pain and trying to get rid of it. And pain is, you often hear pain is a teacher, and pain often is trying to alert us to something. And if we keep ignoring that thing, it can get more and more sensitive. So we need to think about, why is my nervous system feeling threatened? Why is it creating pain? Maybe there are some things in my life that I need to be more aware of and pay attention to. I need to slow down and tap into my parasympathetic system. I need to move and exercise more. I need to sleep better and improve my diet. Like, it's an opportunity for you to listen and step back and listen to your body. And I think sometimes educational resources like that from someone who's really specialized in pain can be a really good place for you to get going.
Yeah, I love that. Those are all super practical tips for people to take away and put into their lives. And Tom, to wrap up, I have such a huge admiration for what you have built in your platform, helping so many people around the world. Can you tell some people sort of where they can find you? I'd love you to tell people about your book, so that we can, support you in your work.
I'd love to be a resource to people too. Pain recovery is really probably my number one passion. And so people can always reach out to me. I'm mostly on Instagram and YouTube as Rehab Science. So people can DM me on Instagram. I try to respond to all those DMs. And then my book is called Rehab Science as well. And it really is it's really a therapeutic exercise book. So each body region has its own chapter. So like if you had back pain, you could go to the back chapter. If you had shoulder pain, you could go to the shoulder chapter. And it covers the 50 most common conditions that I've seen in my career as a clinician. So like rotator cuff injuries, back pain, ankle sprains, like, so you can, it really is meant to be in this line of thinking that we've been talking about, of giving people tools that they can implement on their own when we know exercise and movement have some of the best evidence for pain and injury rehabilitation, a lot of that you can learn on your own. And if you have kind of a what might seem like kind of a cookie cutter program, because of course those things, I didn't do an evaluation on you, so it's not personalized. A lot of times it's amazing how much better people can get on their own when they just have a plan that gets them going in the right direction and gives them some education. So yeah, it's pretty much rehab science everywhere, and people can always reach out to me.
Great. Well, I've used it as a resource personally for my own ailments. I've sent all of these to different clients and athletes throughout my career, and the book's another a tremendous resource. And I think to your point there, I've always viewed this. There are certain things that will get 90% of people heading in the direction that they need to go, regardless of me doing a hands-on assessment. Then the hands-on sort of takes you the rest of the way. But I think there are just some things that will help everybody. And I think your following is a testament to that. If you weren't helping people, you wouldn't have the following that you did. So as I said, a huge admiration for that. And we're trying to follow in your footsteps here and share some of the experiences that I've had and the network that I've been so fortunate to build. So thanks so much for your time today, Tom.
Thanks for having me, man.
We've covered some powerful insights today with Dr. Tom Walters on pain management and recovery. Here are the 3 key takeaways from our discussion. Number 1, pain is not always a sign of damage. The nervous system can amplify pain even after an injury is healed. Number 2, movement is medicine. Finding enjoyable ways to exercise can help desensitize the nervous system and improve pain resilience. Number 3, your mindset and stress levels matter. Negative beliefs and chronic stress can heighten pain perception, so focusing on mental well-being is crucial. If today's discussion resonated with you and you're looking for ways to integrate pain management strategies into your life, Vitality Collective is here to help. We focus on holistic approaches that combine movement, mindset, and recovery to optimize your health and performance. Visit www.vitality-collective.com to learn more. Thanks for listening, and we'll see you again next time. Before we leave, just a quick reminder. This podcast is for informational purposes only and should not be considered medical advice. Always consult a qualified healthcare professional before making any changes to your health regimen, especially regarding pain management and rehabilitation strategies. If you're experiencing severe or persistent pain, seek medical attention from a licensed professional.